Hey, Erika.
Hello, everybody. How is everyone?
Good. We'll give everyone a couple of more to 105, Erika, and then we can start.
Yeah, no problem. So Henry, my setup allows me to, doesn't allow me to look at the chat really easily. So if you guys, I have to share a screen, I guess, which I can do now.
Yep.
But if you can monitor the chat for me.
Yeah, I'll do that. That's not a problem. I like that, Erika.
You like that?
Yeah.
Halloween is a big deal in our house. At least it was pre-COVID. It's hard because I can't make as big a deal of it anymore because there's so many constraints. But I will still dig my heels in and make a big deal of it. So I thought I would make this a Halloween theme this time.
Are those your kids?
These are my kids. Yeah, this was Halloween from a couple of years ago.
Oh, that's awesome.
Erika, I will say that title makes me think of like when I'm doing usually adult path, like for lectures, and I go into like our EMR and open a chart, and it gives me you have opened the chart of a deceased patient. I'm like, oh,
yes,
like
yes.
less of from my PED scans, although every now and then I'm like, oh.
I will not be talking about any deceased patients today, so that's good. But I will be opening the crypt of scary ultrasound stories. Some of them are like scarier than others, I think. And I'm also going to draw from some of our adult cases. So we'll just keep it sort of interesting that way, hopefully. I'll wait for your go ahead. And I hope I don't get into any Keynote glitches. There's been a complaint about Keynote recently on this platform.
Yeah, we had two people that, before it used to be the PC people that used to have issues. Now it's all the iPhone people. So
the tables are turning, everybody.
So I think it's officially 105, Zach. I like to stick to my 105 to give everyone a chance to log in. But yeah, today we have Erika Constantine from Brown University presenting. So thank you, Erika, for presenting, and you can take it away.
All right. Hello, everybody. I'm from Brown University, Hasbro Children's Hospital in Providence, Rhode Island. It is the best time of the year over here. And I think I underestimated New England falls until I actually moved here and realized that it is really, really beautiful. So if anybody hasn't had the chance to see it in the fall, please come on over because it's amazing. And so the topic for today is Tales from the Crypt, stories that scare me. This platform has been so unbelievably amazing with great cases, and I feel like the ability to outdo the previous person is becoming harder and harder in terms of cases. There's always learning in every case, even though it's a simple case and a kind of straightforward thing. So I thought I would draw this week from some of our adult experiences. As you know, we are a freestanding children's hospital here, but I work very, very closely with our adult EM colleagues, and I have the ability to review cases from the adult side quite frequently every week. And so I'm drawing from some of their cases as well. So you're going to see a mix of adult and pediatric cases, and I made sure that the adult cases are going to be things that could be applied in a pediatric setting. So I'm not going to be talking about AAAs today, but some adult cases that could be applicable in pediatrics. All right, so our first case is the case of a 22-year-old female who came to the emergency department with abdominal pain and vaginal bleeding. She knew she was pregnant. She was between 4 and 8 weeks. and came because she had some abdominal pain. Now, she'd had previous pregnancies before, so she knew that this abdominal pain and degree of vaginal bleeding was not normal when compared to her previous pregnancies. So she comes to our emergency department and is triaged, and these are her vital signs. As you can see, she has a normal blood pressure and a normal heart rate. And so she is triaged to our just urgent area and was seen relatively expeditiously by one of the PAs. So quite rightfully, ectopic pregnancy was really high on the list on the differential. So quite quickly, within 20 to 30 minutes, the ultrasound was ordered, and it was a comprehensive radiology performed ultrasound that was ordered. So an hour after that, we get the radiology report, and here's what it says. It says there is a heterogeneous mass-like lesion within the right adnexa that appears to be separate from the ovary, might be an ectopic pregnancy. There's fluid within the endometrial canal. We're not sure if this is a gestational sac, a pseudo-gestational sac, or blood, but they clearly say there's no demonstrated fetal pole or yolk sac. And then they also comment that there's a small amount of free fluid within the pelvis. So these findings were communicated to the provider that is responsible for the patient, and OB was consulted. So I just wanted to review with you guys, these are the radiology performed scans. You can see it's an endocavitary scan. This is the heterogeneous mass in the right adnexa. This is not uterus. The uterus is out of the field here. So you can see it's heterogeneous. It's poorly organized, obviously concerning for ectopic. Here is the empty uterus, which they measured. And so based on that, they consulted OB. So an hour or so later, OB said, order the methotrexate, and you can either give that to her in the ED or she can take it at home. But since her vitals are so stable, she can also be discharged. So throughout the course of that time, the patient was having quite a bit of pain. Her vitals were still stable, but she was kind of like, I'm feeling kind of faint and I don't feel well, so I'd prefer to have it here in the emergency department. So fine, they said, fine, we'll keep her. So then there's a change of shift, and the new provider that comes on happens to be one of our ultrasound experts, and she decided to go scan the patient. And here's the image of the right upper quadrant. And you can see that that is clearly a positive fast exam. And my colleague flipped her lid and called OB and said, this patient has a positive fast and is actively bleeding into her belly. Can you please reevaluate? And the patient was taken to the OR within 20 minutes. So as a review, here is her timeline. She arrives at noon. She has her ultrasound ordered very quickly, 20 minutes. An hour later, the result is there. 2 hours after that, they ordered the methotrexate. Another hour after that, there's a change of shift and the POCUS was performed. And then 20 minutes after that, she's in the OR, leaving for the OR. So the clinical pearl to take home here is that radiology does not routinely check the right upper quadrant for free fluid as part of their pelvic scans or their will ectopics. And I don't know if this is just in our department or whether it's everywhere, but if that POCUS had been performed at the very beginning, maybe it would have been negative. Like she had been there for 5 hours. So maybe at the beginning it would have been negative, but certainly 5 hours later it was positive. And if this patient had been sent home with methotrexate, who knows what would have happened. So certainly a near miss in our emergency department, and a little bit scary, but one of the things that we're trying to kind of teach all of our attendings is that if you're sending somebody to the radiology suite for a rule out ectopic, you must check the right upper quadrant before you send them, because we don't know how long they're going to be gone. We don't know when they're going to come back. And even though they're stable now, they may become unstable later. So as a quick review, because we don't see a ton of ectopics as in the Hasbro ED. When you have a child with a positive beta HCG and belly pain, the first thing to do is make sure there's no IUP or confirm there's an IUP. And in this case, you can see a longitudinal view of the uterus here, and there's no IUP. Next, you want to look at the adnexa, and specifically what you're looking for is the bagel sign. And just as a point, I want to say that this is a Montreal bagel and not a New York bagel. And the Montreal bagel has a bigger hole, so it's really important to remember Montreal bagel. And you can see it right here. There's that tubal ring that we always talk about, but don't always have the benefit of seeing. And then finally, as part of your study, you really want to make sure that you are looking in the right upper quadrant. And that is to make sure that there's no free fluid, because in the adult population and in the older teenage population, most of the free fluid is going to collect, remember, in the right upper quadrant and not in the pelvis like we're used to seeing in the younger children. So just make sure that you are looking at that as well.
Erika,
So,
sorry to interrupt you. There was a question in the chat box about if there was a difference in the patient clinically on the change of shift.
well, the difference was that she went to the OR as opposed to getting methotrexate. They were going to give the methotrexate in the ED and waited, basically. So yeah, the POCUS absolutely changed her management.
I wonder if the implication is like what made the person go back in and do that so much later.
So so remember, it was a change of shift, so she wasn't there for most of the day. And so she had this patient signed out to her and realized that she knew there was an ectopic sitting in her ED waiting for methotrexate, and nobody had checked the right upper quadrant. And she's on a mission. She happens to be on a mission for these ectopics because she's had so many cases of ectopics that get sent to the radiology suite when this is something that she believes within the, which, and I agree with, particularly in the general EM population, this is a bread and butter scan that needs to, you need to know how to do this for exactly this reason, because the patient can go from stable to unstable very, very quickly. And we're seeing a lot more concerns about failure to perform scans than concerns related to actually performing the scan. So I think it's really important to know this skill and know what some of the pitfalls are when you're sending for radiology performed scan, because all these ectopics are like sitting in the emergency department waiting for stuff, right? They're waiting for an ultrasound, who knows, and it depends on when they can take them for ultrasound, and if their vitals happen to be stable at the time, who knows, right? Like who knows when they can become unstable.
Eric, I think
So go ahead.
I was going to say, the other thing, just even I will say, I think the first time I presented this, I had a very similar teen girl and sort of change of shift, and I came on and asked my off-going fellow if he'd looked at a right upper, and he was like, no. And I went in there while OB was talking to the family and saying that he thought she probably had an early IUP and a torsion, and I basically looked at them in the room like, she's got right upper quadrant fluid, take her to the OR now.
Yeah.
But one of the things I noted when looking at that case is that, and sort of perhaps similar to yours, like 22-year-old healthy female with a heart rate of 92 is like technically within
A little high.
normal, but like would probably give me, depending on the habitus and what you're looking at, would give me a pause mostly in a retrospective scope, whenever pop on red in your EPEC, whatever. But that was one that I've also preached to our folks, because I think it was the Murphy study. It's like a positive likelihood ratio of 116, I think, for
Yes.
needing OR management.
Yes.
Which is a pretty robust number.
Yeah. So I just wanted to get home because, or drive that point home, because certainly it's an issue in our department, is that I don't think a lot of people who are not POCUS trained formally realize that radiology hasn't looked in the right upper quadrant, and it's not a radiology thing. The FAST exam is not a radiology thing. Certainly they can diagnose it, but it's not routinely part of the pelvic exam, unless it's become a routine part in other centers. I don't know, is that done in other centers where they actually look at the right upper quadrant as part of their comprehensive scans?
The one I had, they had not. Radiology had looked and actually anchored it as being a torsion or a ruptured appy because she had an elevated white count as well.
Huh, interesting.
Yeah, I mean, I forget the circumstance. Maybe it was, I don't remember, but I've in the past, asked radiology, could you take a look at like the fast views, and they respond as if you have two heads. I can't remember the exact circumstance, but it's not in their like repertoire.
Yeah, it's certainly not their wheelhouse, their usual thing. So
our radiology appy study does a right kidney and gallbladder, like very quick views in the study, I guess, to sort of look for other common like right-sided belly pain things, which would give you a reasonable shot. So they don't do in our pelvic.
Matt, your case was the beta HCG positive?
So my case, it's actually a PEC case at some point. I don't know if it's out or not. It was a young Spanish-speaking girl who came with EMS without any parents and repeatedly denied having ever been sexually active. And so, our RADs won't do a transvaginal on anyone who fits that bill. And so they had sent a blood on her, but didn't want her to pee. They didn't have a point of care on her because they were waiting for her bladder to fill for the transabdominal.
Got it.
And then like right around shift change, all this info came back in a hurry. It was just kind of slowly walking up, like never abnormal, but just slowly walking up.
Yeah. Does anybody have an endocavitary probe that is at their disposal easily? For us, the endocavitary probe, the adult side has one. It is routinely out of commission because we're having issues with getting it cleaned appropriately. So I was curious as to what other people have at their disposal. I know the New Jersey people do have an endocavitary, but I'd love to know what everybody else does for cleaning.
We have ours that we share with the adult side, have a whole like cleaning protocol that goes along with it.
And what's your cleaning? Like, do you have to send it away to?
Yeah, it goes upstairs to central sterile. But to be honest, I'm pretty sure that if we wanted to, it would have like an under 1 hour turnaround time for the cleaning.
Got it. Okay. It's a constant issue for us over here. There's not, I think the latest is that the Department of Radiology was forced by our upper levels to clean it for us. They were very happy with that, but that's the latest. So I don't know what's going to happen with that or how that's going to roll out, but that's our latest solution.
Erika, from Yale, they don't use endocavitary in kids, and at Cohen's, they don't have an endocavitary probe as well. Here in my shop, we do have an endocavitary probe, just like Adam. You have to send it to central sterile. If I give it to a tech, it's a quick turnaround, like maybe half an hour, the quickest. But that's sort of that's our protocol.
Got it. Cool. Thank you. All right. I'm going to move to case number 2. So our second case is also from the adult side. This is the story of a 31-year-old male who came into the emergency department with a chief complaint of new onset seizure. 10 days ago, he was seen at an outside hospital after an MVC. He was at that time diagnosed with an occipital condyle fracture and a splenic hematoma. He was sent home in a Miami J collar and was at home doing his own thing. And then suddenly 10 days later had what the family thought was a seizure while he was in the bathroom. So EMS was called and he was brought to the emergency department and triaged to our urgent area based on his initial vital signs. So here are the initial vitals: normal blood pressure, normal heart rate, and he was seen actually quite quickly by the provider. And in true form on the adult side, it's like, scan everything. They ordered a CT of his head, a CT of his neck, abdomen, pelvis, CTPE, like could be anything. And I have a big respect for the adult side because there's a lot of systems issues, a lot of volume, a lot of different things that it could be. But that's what was ordered for this patient. So he had all of those things put in, and then he was moved to the critical care area an hour later when his blood pressure suddenly tanked. And now he had this new blood pressure of 72/51. And now he had undifferentiated shock. So transported him relatively quickly to the critical care area, and in good form, thanks to a lot of teaching on our side, they pulled out the ultrasound and captured this image, which showed a positive FAST exam, positive right upper quadrant. Great, we're done. And so he had a fewer number of scans performed. They managed to stabilize his blood pressure with a liter of fluids. And so they still sent him to the scanner minus the CTPE. And so they still wanted a head and neck because of this maybe seizure, which in all honesty, everybody kind of realized that it could have been syncope with maybe some tremulousness that you commonly see with syncope. But with this positive FAST, they didn't need the CTPE, but they scanned the abdomen, they scanned the neck, and they scanned the head. So the CT scan showed a splenic laceration with active extravasation of fluid. And because this patient had stabilized, his repeat blood pressure actually normalized after liter fluids, there was a whole discussion with VIR as to whether they should embolize the spleen or whether they should go to surgery. So that whole discussion was happening. So was this a great catch? Absolutely. This is, exactly what I live for, is the great ultrasound, undifferentiated shock. There's your answer. It's great. What's the teaching point for this? And for me, what was the documentation? And we're certainly trying to drive this home in our department. And I'm going to say meh for our documentation, because that image that I showed you was an image that was unlabeled in our QPath system on the date and approximate time where this patient was being seen. There was no name associated with the scan. There was no attending assigned to the scan, and there was no procedure note written for the scan. So I'm just curious as to whether other places are having success with helping people document their stuff a little bit better, because certainly this opens, the department up to great medical legal risk if they document something that, we can't find a scan that supports it. In this case, that nobody is going to question what was going on, but it says positive FAST all over the chart. And if you don't save the images, number one, the problem with it is that we cannot build any relationships with outside hospitals, outside services, because they don't get to see any of our scans. But also, we miss out on some of the billing aspects of the most important part of the reason we're doing ultrasound. So I wanted to open this case up because I wanted to know what other people are doing to get better documentation. And I think part of the difficulty with poor uptake of point-of-care ultrasound in general among subspecialty services is that people view it as like this willy-nilly sort of scan that people are doing at the bedside that has no protocol associated with it and variable training. And so I just want to know what other people are doing. Or is it not even an issue? Like, are you guys not at the documentation phase of things and just in the education phase?
On the
There's a
chat,
lot of issues. Sorry, go ahead.
Cohen said that every ultrasound has to be used as if it's going to be used for medical decision making, as a procedure. So basically, it has to be like logged in.
Yeah, so there's like multiple levels to it, right? There's like, how do you document that you're ordering a study? Is there something easy that's in the EMR? Are you documenting all the necessary patient information on the machine? And then are you documenting the images as you're doing a FAST and going from one quadrant to another? So there's like multiple levels for how we could fail on the documentation side. it's not like the machine or industry makes it any easier for us having to go through IT to have, you know, the perfect setup where you can put an order in your EMR and it spits out the patient's name on a work list and then automatically, passively gives you, you know, sectors to save images in that are pre-labeled. If we had all that, you know, I think we could get around some of these things. And I believe there's an ultrasound company out there that we saw a demo of that kind of has a little bit of that, where like they preset what imaging sites are needed for the exam to make it a complete exam. And
Yeah.
I have to go through them, not to name a company, but you know, otherwise these are all like active processes that in a busy ED with a critical patient, like so easy to fall through the cracks.
Yeah, and it's easy, like in our department, especially, you know, if it's really, really busy, I can totally see how it can happen, right? There's so many levels at which you can fail. But documentation is one of the things that we're actively working on, not only for just good medical legal, you know, practice, but also for reimbursement, because the only way we can support our ultrasound program is through good billing. And it's hard to justify the hospital buying us all this expensive machinery if we can't, you know, justify it from a billing standpoint.
And that atomic case to risk management, that'll justify the next 2 machines.
Yeah, exactly. So here's the patient timeline, just for interest. Arrived at 210, dropped his blood pressure an hour later. 15 minutes after that, positive fast, stabilized his blood pressure. CT pan scan done with a stable blood pressure. Lots of discussion about embolectomy, and then eventually dropped his blood pressure again, got blood and went to the OR and had his spleen removed. And so from a clinical pearl perspective, remember your rush for undifferentiated shock. In pediatrics, I can't say that we see it as much as they do on the adult side. But when you need it, and that's on the PD side too. So it's really important to start getting used to thinking about it and knowing that it's out there for any kid that you see is shocky, but you don't exactly know why. And then also to remember to document for posterity, for medical legal purposes, and for billing. Any questions on that before I move on to the next case? Okay, so our third case is a 13-year-old girl who came to our emergency department with right lower quadrant abdominal pain. She had been vomiting that day. Pain is 8 on 10, remained afebrile, came to the emergency department and had a tender abdomen in the right lower quadrant. She had some rebound. Point of care ultrasound was done. Slam dunk appy, right? So based on that, she went for comprehensive scan. And this was the bladder that they got. And here's that's a transverse view. I just want to show you the longitudinal view. And now it's Jeopardy rounds. What do you guys think about this bladder? And is there anything that you notice about it? If you think it's normal, say normal. If you think there's something weird about it, say there's something weird about it. And keep in mind, I can't see the chat. So
Yep.
if
Julie doesn't think that's the bladder. She's questioning
where's the
the
uterus?
bladder.
That's the bladder.
Always a little skeptical of the bladder
why are you skeptical of the bladder?
because it's too often, other things are too often confused with the bladder.
Okay, so what if I tell you it is actually the bladder?
Okay.
It's not the abnormality.
I mean, it's
Now-
massive as a starting point.
Okay, so I'm gonna say that, to be fair, this is not something that a point of care ultrasound expert would probably notice, but it's important for us to be aware. But this 13-year-old girl has no uterus. So she has, would anyone have picked that up? I would not have picked it up. I'd be like, oh yeah, full bladder, ready to go to ultrasound. That's what would have happened to me. Maybe I would have like looked at this bladder for undifferentiated, belly pain. But I think if I got the appy first, because that's what I was thinking, I would have stopped there and not looked at the ovaries or the bladder, except to say, yep, it's full, send her over to radiology, but she has no uterus. And these are the radiology performed scans. And I just wanted to show you that like she clearly has no uterus. And it was marked as an incidental finding, like, by the way, this child has no uterus. Please consider Mayer, Rokitansky, Custer-Hauser syndrome, which I had to look up. Has anybody heard of this before?
Lily has. She called it before you announced it. So I
Did
was
she
gonna give her
really?
credit.
I'm
Yeah.
so impressed. I'm so impressed because I'm presenting this and I still cannot remember those 4 names. And I remember being in medical school saying, we're trying to move away from all these syndromes that are named after a whole bunch of people because we can never remember what they are. But basically what it is a congenital agenesis of the Mullerian structures. And so often they have intact ovaries, but variable levels of fallopian tube and variable levels of uterus. And then the most important thing to know is that fertility in these children or these patients can only be established through either surrogacy or through a uterine transplant. So with that as a background, 18 months later, she comes now, she has no appendix, and she comes to the department with left lower quadrant pain. And as I like to do with most children with abdominal pain that's undifferentiated, I like to look at the belly relatively quickly. And so this is what we got. And you can see again, there's no bladder in this view or any view. So no uterus. And you can see this like large round structure here that is probably ovary. And you can see peripheral follicles, a large ovary. And whenever it's that big, I always get worried about whether this is torsion or not. So she goes to the radiology suite relatively quickly. And this is the radiology report. Left ovarian parenchyma, which measures 6 by 4 by 4. We're kind of taught anything over 4, you have to worry about ovarian torsion. Certainly 6 gets our surgeons really interested. And it says there is a curvilinear fluid collection with layering debris and suspected twisting of contents, either tubular or intraovarian. So some of the way that I like to learn about all of this is to look at radiology reports and compare them to their ultrasound scans. So here is the radiology scan I actually reviewed this one with the radiologist before talking to all of you, because I wanted to know of interest. They never did a venous flow on this ovary. And what the radiologist told me is that just the layering debris in this cyst and the swirling of contents that they notice around or near the pedicle, which is like here, when he looks at it through cine, he thinks like there is a swirling sort of picture. That was enough for him without even the venous flow to say, possible ovarian or tubular torsion. And so this child ended up, so I just want to show you, here's the arterial flow, but they never got any venous flow. They never checked for it. And there were no images saved. So this kid ended up going to the OR, and they thankfully only discovered an ovarian cyst, and there was actually no torsion. And so they drained the ovarian cyst, and the child still has her ovary. So I was very happy to hear about that. Take home point with this is really to respect the ovary. And I get really anxious about ovaries in general, because even though I can look at them and see them and they look normal in size, I see so many cases where even the radiologists don't really have a good, like a 100% convincing idea of whether they have torsion or not, that I kind of shy away from the ovary. And the frustration for me is I can say, this kid's going to go for comprehensive ultrasound and it's going to be normal. And then they still wait 6 hours in the emergency department. They get their comprehensive and it's totally normal. But I am still not comfortable enough saying this is not ovarian torsion. So I'm just curious from the group. The reason I brought this up is, number one, to show that there is a real limitation to ultrasound for torsion, even to rule it in or to rule it out. And I wanted to know if anybody is ruling out or ruling in ovarian torsion in a way that actually expedites patient care.
We had a couple cases at Yale where early ultrasound definitely expedited the ultrasound and surgical consult, particularly in cases where the patient looked sort of good or wasn't in pain, particularly at that time.
I think certainly for me, if I put the probe on the belly and I see a massive ovarian cyst, I will call the radiologist and say, she has a massive ovarian cyst and her bladder is still empty. Are you willing to take this patient anyway? And they will take it. And so often that will save us, a couple of hours in the ED, but by and large, I feel like these kids are still there forever. And I think we just have to accept that may be the limitation in these girls that come with belly pain. Is anybody ruling it out? Anybody comfortable ruling it out?
I'd say only comfortable ruling it out because I saw a strong ulterior diagnosis, such as like right lower quadrant. Now I've got an appy, and then I feel fine saying you probably don't have an appy and a torsion, and somebody's cutting your belly open anyway.
And is surgery happy with that? Like to go with like no ovarian ultrasound in addition to like your positive appy scan?
Surgery doesn't yet take our appy scans for their own side, so the kid would get. I would basically like my usual workflow for a female, unless they're like slam dunk fever or migratory, would be to order both, and they'll typically go to rads, get the appy. They can see the ovary fine. If not, they come back, and if it was a negative, and they wait for them to fill their bladder and go. And if they were appy positive, then I'd probably stop. And surgery's never like balked at saying, "Oh, we need to see the ovary as well."
Yeah.
Erika, this reminds me of like an anecdote that's kind of like a corollary to what Matt's saying. So did the bedside, found a clear appendicitis. It was one of those where it was taking forever to fill the bladder, called radiology attending to be like, this patient has confirmed appendicitis, this person has appendicitis. Surgeon's not going to do anything until, we get the ultrasound. It's likely going to be like multiple more hours before her bladder's full enough for you to be happy about her ovaries. Will you take her over and just ultrasound her appendix? And this one radiologist who I have a kind of a relationship with agreed to, and then it became this like whole big thing. And we had to have like a conference about the fact that like no comprehensive ultrasound should ever be done in a female patient without including both. And it was just like, okay. Like,
wow, that is shocking to me. Because if it's 4:59 and the radiologist is going home at 5 o'clock, you can be 100% sure that they are going to look at the right lower quadrant and then send them back for bladder filling so that they can come back after hours for an ovarian ultrasound. So I feel like that's sad. I'm sorry, but that's terrible.
yeah.
It's
No, I'd be happy with that, right? Because then at least you can call surgery and be like,
okay, we're done.
The final report's not in, but radiology saw what I saw, just so you know.
Yeah.
I mean, it seems right for a QI where you look at every female positive appendicitis and is there any additional pathology that makes any clinical difference?
Yeah.
Adam,
right.
they weren't even implying that. They were just implying that like, they just don't want to allow for any deviation from this like accepted protocol. I don't even think, yeah, it's like so crazy.
Right. That's the whole beauty of quality improvement, right? Is to try to change like cultural practices that don't quite make sense.
Yeah.
And Erika, just your thing about the ruling out ovarian torsions. I mean, we look at a lot of pelvises, and if I'm seeing the same size ovaries on either side, they look the same, they've got the same chocolate chip pattern, they're in the right locations, we'll move on to other things and not send them to radiology.
And do you document it, Adam?
Yeah,
Like,
yeah.
document the process?
We're ordering it, we're documenting it.
Yeah. Okay.
Are you doing flow, Adam?
No, I don't think
Just size.
it's radiology, because there's dual supply. So, if you see it, it shouldn't make you feel any better. If you don't see it, then that would be a concern. But I think I mentioned before that I'm not really a big fan of our machine's ability to detect low flow. So like, I'm not going to hang my hat on it. But if you look in the radiology literature, they talk about size differential and location being, very key features for identifying ovarian torsion. So if you have an abnormality in one or the other, then, send them to radiology.
Yeah.
Agreed. Yeah, Erika, James is actually Rachel. I mostly use it to get him upstairs. If I have a frank pathology that I can say, take a look at my image, there's something going on. I don't need to fill this girl's bladder, neither do you. And so I can at least cut out the 6-hour rigmarole that way.
Yeah.
Is really tends to be, I don't tend to send anyone home who I don't have a good alternative diagnosis for based on my personal bedside look at their ovaries. Our radiology group is funny. They're the opposite of what you're describing, where they actually, they would prefer us to be as precise as possible. And the less studies we order, they're much happier. So when we put in when they get a kid who's the kid who gets sent up for like ovaries, right lower quadrant, and a renal bladder, we most of the time will get a call that says, which of these do you guys really think is going on? Like, can you narrow a bit? So they are very happy to just do a very isolated look where our top part of our differential is, and then go from there. So we are very much a piecemeal imaging pathway construct.
Yeah.
So a little bit different that way.
Yeah. All right, I'm going to move on to our next case. I know there's been quite a few post-COVID related chest pain presented. I just wanted to present a slight slant to that one, to previous cases that were presented. So this is the story of a 17-year-old obese male who is unvaccinated. He was diagnosed with COVID 10 days prior, and 3 days before presentation, he started developing this sort of chest pain. He was seen in an outside hospital. He had abnormal labs and an abnormal chest X-ray. And so he was transferred to our emergency department for ongoing care. So here are his initial vital signs: a little bit hypertensive, definitely tachycardic, slightly elevated respiratory rate. And you can see he's quite morbidly obese. And then here's his chest X-ray, just limited by body habitus, but a little bit maybe questionable for lots of junkiness. So initial labs, very, very abnormal across the board. Elevated troponin, CK, BNP, CRP, and D-dimer throughout all of that. And here's his EKG, which showed diffuse ST changes and tachycardia. And so I just wanted to show you some of the echoes that were done by cardiology. So this is a cardiology performed echo. And so that's why it's, you can see the probe marker on the other side than what we would normally do. But I understand there's quite a bit of variability in the group as to how you might get your parasternal long. The issue with this scan in general is the patient's body habitus was like quite limited, but overall you can see the mitral valve there that is, pretty much hitting the septum. If there's a pericardial effusion there, it's very, very slight, not super impressive. And so based on the EKG, the initial echo, and his clinical picture, he was diagnosed with perimyocarditis. So admitted to the hospital, his echo was normal. He was placed on BiPAP. He had remdesivir and IVIG. And then eventually he had a CTPE, which was negative. He was sent home with ASA and Lovenox prophylaxis and discharged home. He had a 5-day stay just for the remdesivir and had a relatively uneventful course otherwise. So 2 weeks later, he comes back and he has new onset tachycardia, central chest pain, shortness of breath, and difficulty lying down flat. And so he goes to the cardiologist who had been following him since then. And he was able to get into the office that same day, and he had an echo and an EKG done at the clinic and then referred in because he had a very abnormal echo and he was quite short of breath. So on arrival, here are his vital signs: heart rate 120, respiratory rate 32, still a little bit hypertensive. And his labs looked better this time with his troponin is elevated, but not as bad as the previous time, still with elevated ESR and CRP, COVID negative this time, and adenovirus positive this time. So these are our scans here. Now, you can see probe markers in the other direction, and our parasternal lung is the ED way. If I can call it I should call it the Hasbro ED way, because I'm sure everybody does it a little bit differently. But you can see that his function now is not quite as good. The pericardial effusion is bigger. How many of you actually do EPSS? This is I think maybe more of an adult thing that we like to do. Sometimes, particularly for research, I like to gestalt the overall function. But it's really nice to have this like picture of the anterior leaflet of the mitral valve, like so far away from the septum. And so just for those of you that may not be totally familiar, but here's their anterior leaflet of the mitral valve, and this is your septum, and this is in M mode. And typically, like, these waves like hit the septum, and clearly we're not seeing it here. So very decreased function in this case. And I think what's interesting to me is that the numbers certainly don't reflect how bad the pathology is. And even though, the first time your echo can be normal, but you can still have really, really abnormal labs, it's not necessarily predictive of what your clinical course, like your numbers are not at all predictive of what your clinical course are going to be. So here's his EKG. And the EKG shows again tachycardia, but not as impressive as before, but he certainly still has some ST changes and a biphasic T wave. So certainly not normal, not as impressive as the first time that he came. So he had an echo, like this is the echo that he had that demonstrated that caused his return to the ED. You can see that pericardial effusion again and some decreased LV function. They repeated the scan 2 days later, and they noticed improvement in the pericardial effusion. And they also noted pericardial thickening that is impressive. And I have to say that I probably would not have looked at the pericardium and said, wow, that's marked pericardial thickening based on this image. And I don't think I've ever paid attention to how much pericardial thickening, but I think having reviewed this case, I might start looking a little bit more. And they called this function low normal based on what they could see. And so here's his parasternal short. Like it's not horrible function. Because this child had such limited body habitus, he ended up with a cardiac MRI. And I was gonna like be all fancy and show you pictures of the cardiac MRI. I don't know if anyone has ever seen a cardiac MRI. I had no idea what I was looking at whatsoever. And I thought that my images would probably be lost on at least some of you. So I thought I would spare you the images per se. But I think the most important thing is this patient had an apical thrombus that could not be seen on any of the scans beforehand. And so this was one of the big problems with him that was super concerning. And so he ended up getting a whole bunch of stuff. Eventually they consulted the adult cardiology people because they're like, this child's going to be 18 in like 2 weeks. So he ended up on a whole bunch of cardiac meds related to elevated blood pressure. And so that's what the lisinopril and the carvedilol are for. Colchicine was for the myocarditis, and then actually went home on warfarin because of the apical thrombus. He also had a CT angio, again, that was negative. Clinical pro for me for this case is, your echo can really underestimate the extent of cardiac pathology. I have a deep respect for our pediatric cardiologists who have to scan all sorts of patient sizes and pathologies. And so I think knowing that you can have something like an apical thrombus and not see anything like that on a regular echo is scary to me. I know a lot of, how many people I've seen post-COVID myocarditis that bounce back with another episode of myocarditis? Anyone?
It's actually interesting, Eric. I had a patient, kind of almost the same story as you, was overweight, developed post-COVID myocarditis, and came back, and sort of his heart was still not recovering, so he got admitted again. But sort of same scenario, obese male and worsening symptoms.
Yeah. And in this chart, there was some question as to whether this was a different virus because of the adenovirus. Like I might be adenovirus positive right now, so I don't know how significant that is, but they weren't sure if this was a different myocarditis or the same myocarditis. Certainly it was really unfortunate to see the degree of pathology in this child.
And then a question from the chat was, what made you guys get the adenovirus in this visit? Was it something in the history, or it was just something you routinely get?
It's pretty routine in our shop. As part of his admission, you have a choice of getting a COVID flu RSV or what we call the RP2, which is like 15 different viruses, including mycoplasma and COVID and the other ones. And in this case, they got the full gamut. But certainly COVID negative the second time. All right, last case, we only have about 5 minutes. It's a busy overnight for me, and I'm trying to triage 1 million patients, and I get a call from the transport phone from an outside hospital saying, I have a 8-year-old girl who's here with belly pain. We had a CT which shows a jejunal intussusception. Will you accept the transfer? And I was like, that's a small bowel intussusception. Like, we don't typically do a whole lot for these. We are the regional referral center, so we do not necessarily refuse transport for anybody, but this child might actually have this resolve on its own, and you could send her home. And so the transport person referred that information back to the referring hospital, and then an hour and a half later, or maybe 3 hours later, the patient shows up in my emergency department. So the long story short is they were really uncomfortable. They didn't know what to do with this, and they wanted us to see. Fine, no big deal. So I go into the room, and she looks sort of like unwell, but like non-specific belly pain. And as you all know, I'm an ultrasound educator. So any intussusception, whether it's small bowel or large bowel, I'm all in. I bring in my ultrasound. And not that there was any specific indication to ultrasound her, but I brought in my ultrasound. So just as a background, this is a CT scan. I like to say, if I can find the intussusception, then that's it. It's probably pretty obvious. So here are the intussusceptions, what they call the jejunal intussusception. So On further history, this is a Spanish-speaking family. I realized that she had recent travel to Ecuador. She had 3 weeks of belly pain, diarrhea and nausea, no vomiting. And for the last 2 days, her belly pain was worse, which is what prompted the ED visit. So I put my probe, I knew where the intussusception was. So I'm like, hey, I'm gonna put my probe there. And this is what I see. I don't know how, I'm hoping this transmits pretty well over the over Zoom. Does anyone want to take a crack at what you're seeing?
A hitchhiker from Ecuador.
What's that?
A hitchhiker from Ecuador.
Yes, certainly not an intussusception. Here it is in longitudinal. If you guys can see this linear structure here, we were able to diagnose her with intestinal parasites based on this ultrasound. And so we sent her home with anti-helminthics and sent her on her way. So I like to say that probably nobody else would have diagnosed that. They probably would have sent her home. Maybe they would have done a stool O&P, maybe. But I think the interesting thing for me in this one is just to think about small bowel intussusceptions just for a split second as to whether there's a lead point that you could potentially have that might be causing intussusception. And I think that's what the case was with her. And I certainly, maybe it was a chance that they found it on CT scan because it's certainly not there anymore. And we just got lucky. This is like a whole bunch of lucky things that happened that probably she would have probably had a pretty delayed diagnosis afterwards. As a quick review, small bowel intussusception, I like to say, is like just really cute and little and usually less than 2 centimeters. And there it is in short axis on the left and long axis on the right. Large bowel intussusception is a lot more messy looking and a lot bigger, usually greater than 2 centimeters, and in long axis looks like a pseudokidney. And I think all of us get really excited about these large bowel intussusceptions and not so excited about small bowel. I think the exciting thing about this is I happened to catch this cool hitchhiker, like Adam likes to say. Clinical pearl for that one. Think about the pathologic lead point for any intussusception. I'm really glad I didn't poo-poo the transfer too much because she probably would have had a delayed diagnosis otherwise. Ultrasound is awesome. That's all I had to say. Any questions about that one?
Well, that was just such a great case, Erika. That was awesome that you captured that. I captured, this was I was in residency. I went to Ecuador, and then the radiology captured it on the actual gallbladder. So.
Oh, interesting.
Yeah, awesome that you got it. So yeah, that's fantastic.
All right, and on that note, that's all I got. I hope you guys have a really fun Halloween, and that that you can at least manage some trick-or-treating or something.
Yeah, thank you so much, Erika. And then I was going to ask, hopefully enough people stay on, for filling out the bladders, does anyone routinely give Lasix to help with filling the bladder by any chance?
I don't routinely do it. We did have a protocol in Boston to do it when you had high suspicion and high concern. So it definitely was done there. We don't do it here. We do have bladders. The only thing that's expedited things for us at CHOP is that we have bladder scanners now that we actually have even though we have a bunch of ultrasound machines are being used so often that it was hard to integrate them into the pathway because there's so much use of them. So we actually now have bladder scanners that allow the nurses to do the bladder scans and prep for patients to go up to radiology. And there's real-time communication with radiology about the bladder volume. And we've created standardized bladder volumes with radiology that they will accept for a patient to go up. So there's no more of that like up and back situation. It's just, they have the volume you asked us to have and they get ready to come up and they can just come up. So that has helped some.
Henry, can you hear me? I'm in my car.
Filled up enough.
Yep.
Sorry, Henry, can you hear me?
Yep, I can hear you.
So I've never done the LASIK thing. What I tell our fellows, if that's their high concern, like their textbook, that they should go like Foley and retrofill and just be done with it right then and there, which is obviously more invasive, but seems worth it for a gonad.
Yeah, definitely. Yeah. So, all right. I would just because we're starting to use it here, and I'm starting to study on it as well. So, but yeah, so I just want to see what if there's a lot of people that were using it or not. But yeah, but thank you for the and then thanks everyone for joining this week, and see you guys next week.
Thanks,
Thank you,
everyone.
Erika, again.
Thanks, Erica.
Right, bye.
Erica, do you have any good
Great.
costumes for your kids for Halloween this year?
Well, now like they want to plan their own costumes, so they don't have.
no.
So
Well,
now
they-
my creative outlet has been hijacked a little bit.
I know, I was gonna say that was like a huge, like that was like you got so creative and like
Yes,
like a
That's my
full-time
fun
job. for
thing.
you.
Now it's like, Mom, you're just not cool enough. I'm doing my own.
So what are they gonna
Which
do?
is okay. It saves me some work and some pressure deadlines. So,
All right.
all right. Bye, everybody.
Bye.